So depression, it actually comes in a few different varieties, but from a clinical point of view, from a diagnostic point of view, but really there are two core elements of depression, and sometimes they go together and sometimes they really just exist on their own. The one that almost all of us think about when it comes to, what is depression? It's a sad, blue, low, down mood where people feel different than their usual self. Things happen in a person's life, right? Sometimes bad things happen, and it makes sense as you feel sad. But for most people with depression, it feels, it feels different. It feels like not their usual self. And probably one of the most important single symptoms of depression is this sad, low, blue mood. Sometimes people don't quite describe it that way. They might describe it as just losing a lot of energy and feeling just slowed down. But really, sadness is a big part of depression. And for many people, that's what's most painful, and that's what they notice first. Another important side to depression is losing interest in things. The things you used to enjoy or things you used to like to do. For many of us, we have a certain thing or two or three that really helps keep us elevated. And, for us, for me, it might be outside activities. For you, it might be something like art or reading. Everyone has their own group of things that they're interested in. But when depression arrives in a person's life, often people lose interest in those things that they used to enjoy. So art doesn't seem as interesting to do, or listening to music isn't quite the same, or talking to a friend if that's what you like, or taking a walk, or watching a movie. It just seems dull. It just doesn't seem attractive anymore. And those activities really help to sustain us. And when they don't seem really interesting anymore, often people just stop doing them. And so these two things usually come together, feeling sad, blue, and down, and also losing interest in the things that used to sustain you, things that you were interested in. Depression can come also in different amounts or lengths of time. There is something we call major depressive episode or major depression, which is a period of at least 2 weeks. That, in a way, it's different than your normal way of feeling, your usual way of feeling, where you feel every day, nearly all day long, either down or disinterested or both. And it may come many times in your life. It may last for just a few weeks, or it may last for several months. But it's different than your usual way, and it comes in a kind of an episode. So that's major depression. Major depression comes along with feelings other than these two that I've mentioned, the sadness and the lower interest. Other things can come along with it, like difficulty sleeping, or problems with your sleep is probably a better way to say it. Because sometimes when people are depressed, they sleep too much. They just feel tired all the time. They sleep in the day, they sleep later than ever, and they just feel exhausted and tired. For others with depression, they might be tired, but they can't sleep. And sometimes people have trouble falling asleep, so it takes much longer. Or sometimes people have problems waking up in the middle of the night and not being able to get back to sleep. And for others, they sleep fine for a while, but they get up much earlier than they expected. And that often leaves people with depression tired. So sleep is a big part of depression for many people, and an important thing to keep in mind. When you're trying to understand what's the difference between feeling sad after something bad happens and a mental health problem like depression. So sleep is important. Again, we mentioned that sometimes people have very low energy. Ironically, sometimes people feel really sped up. Like they're moving quicker and they're moving more than usual. They feel restless. So it can either be moving more slowly and feeling very low in energy, or feeling agitated or restless. Then for some people, they lose interest in food, so they lose weight, or Conversely, like a lot of these things, on the other side, sometimes people, when they feel depressed, eat more than usual and gain weight. Sometimes people feel really guilty, like often really for not much reason. They just feel guilty. And, for others, they feel like, there's not much sense to continue. And they worry about maybe what the future might hold and whether they're going to continue to feel this way. And sometimes people, when they're depressed, they get to the point where they want to end their life. So thoughts about suicide or planning suicide, that can be part of depression for many people. Not for everyone, but for many. So think about major depression as this intense period that's different than a person's usual feelings in their day-to-day life, that often can come on fairly suddenly. And for many people, it just feels different than usual. And they can last from 2 weeks all the way up to months at a time. In addition, with major depression, you have a cluster of these problems. Difficulty with sadness, disinterest in things, sleep problems, feeling slowed down, feeling agitated, having difficulty concentrating, a whole list of things that go along with it. The main thing is that major depression is difficult to live with. It's, it's like depression, I guess, demoralizing. You might wonder, how many people get major depression at some point in their life. And about 20% of people at some point in their life will have an episode like this that lasts at least 2 weeks. And that makes it perhaps the most common or among the most common mental health disorders. So many of us have experience with this kind of a feeling. Sometimes it comes out of the blue, but more often there are life events that are connected with the onset of depression. So especially events that involve loss, like the death of someone close to you, perhaps a relationship breakup, perhaps even moving away, or even starting a new job and leaving others behind. That a loss-related life event is often associated with the onset of depression, but not always. Sometimes childbirth is another time just after childbirth where depression might be more common. Also, sometimes when people get a medical condition that interferes with their ability to live the way that they lived before, or potentially even a life-threatening medical illness, depression can often go along with it. Depression is different than many other mental disorders in that you have risk for it over your whole life period. Many mental disorders, like anxiety disorders, for instance, or other mental health conditions, your biggest risk is when you're younger, from your childhood up until your early adulthood. But depression can come, major depression like we're talking now, can come early in your life, but you can also many people experience the onset of major depression quite later in their life, in their 60s or even 70s. So we've talked about this episode of depression called major depression. Another way that depression presents itself is in a longer period of time, where it's in a persistent mood disorder. And that is for at least a period of 2 years or more days than not, you feel pretty much down and blue. The same kind of symptoms. You might also have experiences with loss of interest in activities, pastimes. But this is a kind of an enduring, longer pattern of feeling this way. And many people get this form of depression too. And sometimes people have both. Episodes where it feels very strong and persistent every day, and it kind of comes and goes in shorter periods of time. And at the same time, they've also experienced some of these longer 2-year bouts of sadness and feeling blue and down, this persistent form of depression. When you take both of these two kinds of depression together, we don't know for sure all the risk factors. What's causing this? But we already talked a little bit about life events, and they certainly seem to play some role in the onset of depression. But in addition, and we also talked about pregnancy, that might be a risk factor. There's probably there's a fair amount of evidence suggests that your genetic makeup or your body has plays some role in your risk for depression. It's probably a combination of life events and your family history that come together to cause this problem. We'll know more about the causes of depression as the decades roll further. We've learned much over the last few decades about what are some of the contributing factors, the things that lead to depression. But we're pretty sure that it's kind of a environment or your life circumstances and your body that come together to increase risk. One thing that is for sure is that if you've had one depressive episode or one problem with depression, your chances of having another are much greater. So unfortunately, when people have depression for the first time, it's often not their last. And for many people, the problems come very often, and continuous treatment is the best choice in those circumstances. So we've been talking a little bit about how low mood can connect with what's happening in your life. And that's normal. It's usual. When something bad happens, it makes sense that you'd feel sad about it. And there's nothing wrong with there's no mental health problem there. And then we've been talking about major depression, where you feel these things nearly every day, all day long, for at least a period of a couple of weeks. And then we've been talking about this persistent depression that lasts 2 years or more, where almost every day you're feeling depressed, down, blue, and not having much interest in activities, pastimes, and so on. But it's also clear that there's some kind of a middle ground, where it's not the usual feeling that you would get when things aren't going so well, but it's not quite as intense and quite as often, or not so much every day feeling this way, but somewhere in the middle. And we call that subclinical depression, but it may not meet the full diagnostic criteria for a mental health problem, but it's clear that this bad mood is interfering with day-to-day life, making it harder to enjoy your life, taking some of your energy from you. But maybe it isn't every day, maybe it isn't all day long, maybe it isn't so strong, but for many people, they could still really use some help if their depression, their sadness, in this case, is present pretty often and is beginning to interfere with their life. Let's imagine that we have a new type of depression to think about, or sadness to think about. We talked about major depression, 2 weeks or more, often several episodes. We talked about persistent depression, 2 years at a time, almost every day, but maybe not quite as significant as major depression in terms of how strong the depression is. And then we have many people who maybe have sad mood that comes in and out of their week and sometimes lasts a few days, sometimes goes away for a while, but it's with them quite a bit. We would call that subclinical. Maybe not quite meeting full criteria for a mental health disorder, but it's clearly interfering with a person's life. So clearly, one of the biggest challenges in depression is that sometimes people feel that they're not really sure they can go forward. They want to move on, that they would like to end their life, or at least they think about it a lot. And most people with depression at least have had some thoughts about ending their life. For many, it's a fleeting thought that happens occasionally, and their risk is very low. But for others, the risk is higher. And we have several ways to try to assess whether someone's at risk to hurt themselves, and then we have different routes to try to respond, try to lend a hand. So first, we have this in the field of depression, we often call it ideation. But really, it's just a word for having thoughts about ending your life on your mind quite a bit, where the thought about ending your life is in your mind often, thinking about it often, perhaps seeing it as a desirable way out, or being very worried that you just might be running out of energy and that it seems like a way of escaping how a person feels. And As persons who are trying to help people with depression, it's our job to try to ask about it, because for many people who are having this on their mind, they really don't want to share it, because in a way, they often don't want to admit it to themselves. They don't know, when do you actually decide to tell somebody you're thinking about ending your life? It's not like there's a convenient time for it. So I think a lot of times people might think, gee, I should maybe share this, but when would I, and what would it be like, and what would they think? Will they take me off to the hospital right away? So part of our job is to anticipate that people with depression are likely going to be thinking about this to some degree. And for many people who have depression with thoughts about ending their life, it's a relief to be asked. So our first step in assessing depression is to make sure that when we're working with people who are experiencing depression or low mood, that we ask about suicidality. We ask about whether they're they're thinking about ending their life, and whether it's been on their mind quite a bit. Almost anyone who has attempted suicide and then survived it will say that there was a long period of time beforehand when they were thinking about it a lot. So this is our chance to ask. And in assessing suicidality, I don't think you have to worry about whether you ask it just perfectly. The idea is, have you been thinking about ending your life because of all that's happening, is a great way to start. Then you have to think about, how to assess the risk. Obviously, many, many people have had thoughts, perhaps even you as a potential helper of people with depression have had this thought that maybe I'd just be better off dead. I think people have that from time to time. But how do you assess the risk? We call these risk and protective factors. And they're not foolproof. But there are some things that seem to elevate the risk of following through with an attempt. One elevation is whether you've had an attempt in the past. So if somebody does say that they're thinking about suicide quite a bit, we want to know whether they've ever acted on an impulse or acted planfully to try to end their life. So we'd like to know whether they've had suicidality themselves, whether they've actually tried to end their life before. If they haven't tried, have they made preparations? So have they written a letter, or have they gathered whatever means might be reasonable? Have they done that in the past? We're interested in that as a risk factor. Obviously, if people have planned it out before and began to make preparations, their risk of actually following through with an attempt is much greater. Interestingly, also, if they've had a family history of suicide, someone in their family tree has ended their life, there is a greater risk that they might act on their impulse to, or their plan to try to end their life. So that's an important risk factor. Other risk factors are people who are involved in substance abuse. So we do know that people who have a history of abusing substances, and particularly those who are either drinking too much or using illicit drugs, are at greater risk to make an attempt. Also, people who live alone. There's loneliness and depression often go together. When people are feeling depressed, they often step away from their usual group. So that can be part of how loneliness comes into depression, and that is when you start to feel sad, you begin to step away from people, often because you think it's not going to be of much use to spend time with them. And also, sometimes people are worried that folks would not be interested in talking with them. So being isolated is another very important risk factor to consider. Also, when people are having a great deal of difficulty sleeping, especially not getting enough sleep, that can elevate your risk as well. In addition, people who have strong anxiety, particularly people who are experiencing panic attacks, which is a sudden surge of unexpected anxiety, the risk increases as well. So when we're asking about kind of what people have been thinking, how much they've been thinking about ending their life, How intense and how frequent is an important element, but then we begin to ask about these risk factors, like living alone, like using substances, and I'm sure we'll have a chance to study even more potential risk factors as part of this program. Then we're thinking about what are some of the protective factors? What are the things that make it somewhat less likely that someone would act on their desire to end their life, or at least their thoughts about ending their life? One thing is sort of the opposite, and that is, do they have a close, confiding relationships with others? Are they in contact with others? For others, having a religious or spiritual life can sometimes be protective against ending one's life. Also, having folks who depend on you. It's certainly not a foolproof, but for many people, when they have children or others or elders or people that are really depending on them, that can help prevent or be protective against suicide. Those are just some of the many protective factors that could be important to talk about when you're trying to understand, is this a person who has occasional thoughts about ending their life, or is this a person I should become more concerned about? And as we become more concerned about people, then we'll think about what to do. So now let's imagine we've understood a little bit about how much they're thinking about. We've begun to assess some of the risk and protective factors. The next big element of understanding is planning and preparation. So it is really important to ask a person, what have they done so far to get ready to end their life? What have you been thinking about in terms of a method? It's sometimes really better to just assume that they have been and to ask them in that way, because if they haven't really been planning and haven't really been preparing, they'll say, well, I've not gone that far. But if they have planned and you say it in a way that suggests you're open to hear, then you're likely to hear about things like, I've been collecting pills, or I bought a rope, or I have a handgun. That's what I've been thinking about. Or I've been picking out some places where I might drive my car and crash into something or go over an overpass. Those are the things you want to hear about. And when we're thinking about suicidal plans, we're thinking about how likely it is to be lethal. That's an important part. So sometimes people have a plan that is not very likely to end their life. But for others, especially those interested in or thinking about using handguns or any kind of a gun to end their life, then their risk factor is much greater. So we want to know about their ideas about planning and preparation. Now, if you hear that a person is thinking, well, maybe I would just take a couple of pills and drink a glass of whiskey, they might think that puts them at risk for ending their life, but it's not likely in your mind that this could actually succeed in ending their life. Well, I think that gives you just the most minimal amount of comfort, because you have no idea really as a clinician whether they're going to change their mind. So planning and preparation is really important as part of your assessment of suicidal thoughts, suicidal ideas, suicidal impulses, and depression. So we're going to be asking, is it on your mind? Tell me about it. And ask it in a way that suggests you're open to hear about it. And it's not unexpected to you. This is what happens with depression. Then begin to ask about those things that seem to be increasing their likelihood. Those things you already know about that seem to be increasing their likelihood of acting on a plan to hurt themselves. Ask about that plan and find out the details. The farther along in that plan they are, the greater the risk. And ask about and think about the means and whether in fact they are thinking about a method that's very likely to succeed. All in all, there's only so much you can do as a helper in detecting and responding to suicidality, but it is a big part of working with people with depression. And even if they don't quite meet the full mental health diagnostic criteria, sometimes people can really feel that their life is really not worth living at this stage. And we're here to try to understand that and try to give some help. So assuming you're working with someone with depression and you begin to worry about them. They have thoughts and a plan, which are usually the two things we're thinking about the most. And if we have a thought and plan and some preparation, then we're worrying even more than that. Now, sometimes people will make a commitment to you that they're not going to end their life. Sometimes those commitments are useful, but often it's really hard to tell. People aren't really always able to keep their word. So that's part of it. We really want to ask them, as part of our understanding of what to do, is, are you going to end your life? And when might that be? That's an important part in planning out action steps. Assuming we feel that they are at risk, we've considered the risk factors, the plans and preparations, and they're admitting that they are expecting to end their life. If all of those four things are present, we've got to absolutely take action. We often take action even when all four of those are not present. But one of the things that we attempt to do is to try to find a way to help people remain safe until they change their mind. Often people who have attempted suicide and they survived it later are happy that they didn't die, that they survived it. Because we all know that moods can rise and fall, and depression and the desperation associated with suicidality can change over time. And often people, when they have a little more time, perhaps they have a little relief from the stressors of day-to-day life, can start to get their perspective about what might be ahead in the future, and to think a little more hopeful about whether their life is worth living or not. So one of the things we're trying to do is to get them to safety. And for many people with very strong suicidality, a hospital, a psychiatric hospital or a medical hospital, spending some time there is one of the ways we address suicide in this field. Certainly, when they're actually in the hospital, their risk of harming themselves goes down. Certainly people do sometimes succeed in ending their life even when they're in a hospital. That can happen, but the odds go way down. So hospitalization is one important route for managing this kind of risk. And one of the things that's really important when thinking about suicide risk and helping to take action is to not leave it up to yourself. That this is a time when you think somebody's at risk, they're talking about, they have a lot of thoughts about it, they have plans, they're taking preparations, they can't commit to their own safety, all those things might be in place. It's important to get a colleague, to get somebody else involved, and to talk it through with them. Sometimes it's even nice to have another person meet with the individual to get their assessment as well. It's always nice to have more than one piece of clinical input when you're thinking about what to do next. Many, if you really feel that the person is at risk, many hospitals have psychiatric emergency services. Not all. Sometimes in rural areas and sometimes in underserved urban areas there isn't a specialty psychiatric emergency room, but if there is one, it's a good place to consider. But a regular emergency room is useful as well. So that's one route, is this protection. Another route is to increase the contact we have with people, but not necessarily put them in the hospital or have them go to the hospital on their own accord. If you decide that hospitalization is not a great fit, then one possibility is to increase the amount of contacts that people have. In this particular study, obviously we have a plan for people to participate in these groups and or to participate in the individual treatment. But in many cases, they might need more. And a person can step away from this study and get more intensive treatment. And sometimes that's what we call intensive outpatient therapy, where they go every day, or day treatment it's sometimes called, or just more visits with an outside counselor. In addition, sometimes treatment is changed. Medicine is added, medicine is increased. So it's not only the psychological treatment which might be increased, but also the medical treatment as well, the pharmacotherapy or medication therapy. or other approaches like that. Another thing that we do when people are at risk for suicide is to try to get close people in their life, try to help inform them that this is going on. Often they haven't told people who are close to them. And letting people know, family members and friends, that this is happening can often be really helpful for people with, who are experiencing suicidality or having thoughts about ending their life and significant plans for it. Now, it's best, of course, if the person themselves agrees to talk to their loved ones about it or a particular person about it. But occasionally, when things are really risky, it's important for us to break our confidentiality and go directly to talk to a family member or a close friend, particularly a family member. The same goes for hospitalizing. Sometimes people don't want to go to the hospital, but if their risk is great enough, people can be hospitalized without their consent. And that's always a difficult time. Most of the time it doesn't happen that way. But please understand, our main goal when somebody is at great risk is to try to help them be safe. And safety is increased by the place you are in, like a hospital, the people you're seeing, like your professional clinicians, and also the support you're getting from your family and friends. All of that, all three of those things are sometimes done together in a way to help a person have a chance to see that their future might be better than they thought, and that the treatments they're getting could be made even better.